Hello everyone and welcome to Clinical Research 360 and I'm your host Urvish Patel. You can contact us through email, phone or WhatsApp on the information you can see on the screen, as well as you can join our community on Facebook and the detail of Facebook groups of Research Update Incorporation, which is our non-profit organization, as well as our Clinical Research 360 group. You can join those group and post your questions and your feedback there. Thank you for joining the session. We will start the session in a moment.
Today's session will be completely on the introductory part, introduction to the clinical research. Let me tell you few instruction. On your right side, we have the chat box option. You can write your question there, and I will answer those questions afterward, as well as you can raise your hand. I will unmute you so that you can ask question directly to me. The prelim session will be 40 to 60 minutes an hour, and then we'll take Q&A quickly. Okay, and this all the videos will be uploaded either in Facebook as well as on YouTube, so you can watch these sessions there. Let's start today's session with introduction, the type of the research, and some of the people are here new, some of the people already have experience of research. Some people who is in US, they are doing residency or in medical school or applying for residency or physician. They knows what is the type of the research, or how you are doing research, but how your publication or how you present your work, that is the challenge for them. The people who are not in US, for them the basic fundamental thing, what is the research and what are the type of the research, that is the trouble. So let's start with the type of the research today. So when we talk about the type of the research, in our mind, majority three different type of research comes into the mind, in our brain picture. Number one is we will talk about original, non-original later on, but number one major type, there are three major type. Number one type is observational studies. Those observational studies are the studies where there will be no intervention going on. Basically, you are collecting, or you will be collecting, or you had collected the data, and you are simply retrieving back. You are taking those data back and you are analyzing, and you are checking your aim and objective and hypothesize whatever you wish to see. So I'm just always keeping one example, one easiest example in mind, and we'll try to check that example in every type of research. For example, if I'm checking that smoking cigarette will leads to cancer or not, or the people who had cancer, they were smoking cigarette or not. So basically I'm checking here the role of cigarette and cancer. In that case, it's not recommended to, or not needed to do any other studies like intervention or something. Simply observational studies are enough. And then in that case, we either do retrospective studies. So we will take the records from the back dates, and then we'll see this association between smokers and cancer. Or we will today hypothesize everything. We will decide the aim and objective of our study, and we'll check in the future. We will start collecting data from today, and we will decide the date until what we need to collect or sample size, and then we will continue to collect. That is called prospective study. The third type of studies are cross-sectional studies. So today you are deciding, and whatever timing you choose today, the record will be collected only and only today. So for example, a good example will be like you wish to see the effect of meditation or yoga on hypertension. So you 15 people, you will tell them to check their blood pressure. They will check their blood pressure, have a 30-minute of session, and then right away you will do another thing, another measurement of blood pressure, right away you can find out what is the effect. That is a kind of, it's not a real intervention, but it's a kind of cross-sectional study. Right away you can find out. Or today you want to see in, let's say, New York, what is the prevalence of the COVID. So right away I'll check the data of my hospital, and we'll find out today in my hospital 2000 patients of COVID positives are there, and out of that how many were having pre-existing hypertension. And today whatever data I'm having it, I will analyze and put the correlation between those two. So that is called a prevalence study. We'll come to that thing in detail one by one. And also some of the rare disease or some of the new disease like COVID-19, we do epidemiological studies. So let me take one by one in detail, and then I'll tell you with the example how we can go with that. So let's talk about first retrospective cross-sectional study. So here, when we talk about retrospective study, let's start about two. One is case control study, and second one I'll right away compare that with the cohort study. Okay, so usually cohorts are prospective most of the time, but we'll talk about retrospective cohort as well. But case control studies are very famous studies where usually you are looking the association of disease and so cases means disease, control means no disease, and you are going in the back in the past, and you are looking for the association of some risk factors. So I'm checking cancer versus no cancer, and I'm going back to see the role of smoking, right? So this is the cheapest study which we can perform. We don't have to worry about the money because the data is already there, and we are just finding out today in today's file, whatever in the today's electronic health record, or some countries are having files. So we are finding out how many patients today had cancer, how many patients today did not have cancer. Those 100 will take those data and will open their records and see that they had smoking history or not, right? Very simple. And then in that case you will collect the data. We will come to the data once we are reaching to detail of those things, how to collect the data and stuff. But once you will collect the data, and whatever measurement you are getting, whatever EHR is electronic health record, basically electronic health record. In US we are having electronic health record, and in other parts of country they are having manual files. So that is the way we are collecting the patient's record, right? Some countries they are giving the record back, but in order to do the research, you need to keep the record of the patient with you, right? So the measurement of the severity or the gravity you are going to get, the relation between smoking and cancer in the case control study, that you are going to get it in the odds ratio, so basically when whatever I'm teaching you here, everything is available in the books of preventive medicine or of public health or anywhere. So basically here we are not teaching a proper concept of anything. What we are teaching it, we are teaching how to do the research, basically. So when you are reading next time, or when you are considering your research, you have to make sure that if I am doing a research kind of case control studies, I must mention odds ratio in my paper, right? So that is what we are teaching here. Now what is odds ratio? On that books over books you can read that what is the odds ratio. We will also try to teach you how you can calculate the odds ratio using sophisticated free tool available online. Okay, so retrospective study, which we call it case control study, make sure that study will tell you the odds ratio. In that study, it's a cheapest option, the best option. Without resources you can perform. You though you need, if that study occurs in your hospital. Today we will also have a little bit of idea about which study require IRB, institutional review board permission, or ethics committee permission, which study will not require. Also that we will also tell you something, and in future session we'll try to cover everything in detail. So case control study will give you odds ratio. That is the best study among all of them. That is the cheapest study. After doing cross-sectional study, we'll come to cross-sectional, I'll tell you. So that is also the very resourceful study, and it's also powerful study. Now the second type of study is cohort study. The people who already are in US, they probably knows what is case control and cohort, so this will be very quick, refreshing their knowledge as well. So cohort study usually are prospective. uh, uh, Cohort studies are prospective usually. If you see here we choose cancer versus no cancer, and we look for smoking, we look for risk factor. It's completely opposite. Here we went in the past, we took the record of the past. But compared to case control, in the cohort, in prospective, we will see today. You will not, if you want to do it prospective, is future, you can't predict the future right away. So here we will take the history of smoking today. 100 people with the smoking, 100 people with the smoking, and 100 people who were not smoker. Now for those 100 people, we will track it for 5 years. We will track them. I'm just giving you all hypothetical numbers, okay? It's depend on what is the aim of your study, objective of your study, how you would like to continue your research, and what are the resources you are available. But hypothetically, you are tracking them in the future. Once you track them in the future, then you will see after certain duration how many will develop cancer, let's say, right? For example, so how many of them develop the cancer, and then whatever you are getting, that you are getting parameter in relative risk. So that answer, so the answer you are going to get it, let's say you got the 5, we will tell you how to get it 5 times, so you will get the answer. Compared to non-smoker, smoker are having 5 times higher risk of developing cancer, right? So this is something you are going to get it. But now you can imagine, if 5 years or 2 years or even 5 months you are tracking the 100 patients, so how many problem you will be creating. You have to keep tracking those patients. Number one, you have to spend money on that future follow-up visits. You have to make sure that those smokers, non-smokers patient will not lose the follow-up. They will sometimes forget the history, whether how many cigarette they smoke or not. So there are so many biases involved, as well as it's a time consuming, it's a resource consuming. So this is not very famous studies. It takes a long duration. After 5 years you will try to collect the finding, analyze that, and then try to publish your finding. Now, very important thing, any research that will not publish has no value. Any research has no publication, has no value, because then you cannot tell your finding to the people, right? So it's the same thing. If you are in a medical school and you do not have a degree of the doctor, then you can't treat patients. So value of a medicine is good, but you need a degree to practice it. It's the same thing. You need to get it published, otherwise there is no value of your work, right? It will not recognize. Okay. So let's get back to the cohort one. So that's why to solve this prospective, the solve this problem of 1 second, my screen, hold on 1 second. Yes. So to solve this issue with the prospective thing, the solution has created that we are doing retrospective cohort. Just one second. I think it looks like the screen stuck. So we have created retrospective cohort. In retrospective cohort, the same formula, same method we will be using, exactly same. We are not going to change anything. The only thing which will be changing, that is something called, we will be having here a smoker, we will be having non-smoker, and everything will be today. Today we will be collecting the data of smoker, we will be collecting the data of non-smoker. But what we are going to do is, we will call them, or we will check their record after 2 years ago or 1 year ago, or whenever the record, let's say we'll decide 1 year ago how many patients were smoking. So I will call them, or I'll contact them through a standard system according to the standard IRB permission, and whatever we are having it, we will contact them and we'll make sure that we follow the protocols. And then we ask them, one second, hold on, just, you can, yeah, I think I was like, why you cannot see the screen? Yes. So it's called prospective cohort. The same thing you will be following. You will be having 100 smoker, you will be having 100 non-smokers file, and you will be contacting the same people, the smoker, and then you will call them that, okay sir, are you a smoker till today? And the guy smoker, then you will call them, okay, come today, and we will take the history, how many packs of cigarette you are smoking, what are the other symptoms, what are the comorbidities. So today we will get that 100 smokers history, 100 no smokers history, that I'm having X comorbidity, Y comorbidity, I'm on this medicine, and similarly I'm having all history of non-smoker too. Today I'll tell them, let me pay you the research pay for them for the checking whether they develop the cancer or not, because these guys are having 5 years of history of smoking, and this guy were not smoke any cigarette for 5 years, right? So now today all the testing will be done, all the testing will be done for tuberculosis or for the smoking, or depend on the whatever the hypothesis is. And today if any of those 100, let's say five find out the cancer, right? And here we did not find out the cancer, or here in non-smoker we find out 3 cancer. So this data will be evaluated for prospective. So this is not this is cheaper than the previous resources because it's a quick study, but still here we are using risk factor, no risk factor, and today we are looking for the disease. Risk factor, no risk factor, and today we are looking for the disease. So this is prospective cohort. So let me just give you the brief again when I talk about retrospective and prospective. Okay, here I can have number one, case control, and here I will have majority cohort. And here in retrospective also I will put a cohort, but that is the way I mentioned. But majoritarily, what is the case control? Case means disease positive, control means disease negative, and I'm looking for risk factor. Cases for disease positive, control for disease negative, I'm looking for risk factor. And what I'm going to get it is risk ratio. It is risk ratio. In cohort, I'm going to get it risk factor positive, risk factor negative. Either I will track the patient from back to the today or from today in the future, and I'll see whether disease develop or not, whether disease develop or not. And what we are going to get it is called relative risk. This is concept number one, and this is which we are going to use it for observational study. Now the third type of study we are having it is uh, is cross-sectional prevalence studies. Many studies are cross-sectional prevalence studies. As I mentioned, that the cross-sectional prevalence studies will give you again risk ratio. Similarly, like this, I'm going to make sure today in the hospital, whatever disease I want to look, today only, today's record, I will open it. Whatever hospitalization occur, I'll pull the data, or this year's data, I'll pull it, and I'll see that whether I'm having this risk factor in my hospitalized patient compared to I'm having this disease in my hospitalization patient, and I'll do the study. It will give me odds ratio. The odds ratio and relative risk, I will share the link if you wish, if anyone wish to know. On YouTube, those lectures are available how to calculate by hand. But when you are doing your study, that learning the odds ratio and relative risk is easy by calculating by hand. But when you are having a very complex data beginning from 100 to million, right, your hospital data will be of 100 or 150. The national data of ours, we are dealing with a million patients, so then you need a sophisticated tools to count it for you. Okay, so that is the cross-sectional study. Now, epidemiological studies. Epidemiological studies are the studies which will tell you the epidemiology of disease. It's a huge big word, right? What is epidemiology of the disease? Now, epidemiology of the disease will take each and every studies in detail. Epidemiology study, how it look like and everything. But epidemiology means it will tell you the patient's characteristics. Disease characteristics means how many patients were, how many patients, I'm typing but it's not coming up. So how many patients were male, female in the rare disease. No one would like to know that in MI, angina or cardiac failure or some stroke, let's say, what is epidemiology? No, but everyone would like to know about COVID-19. What could be the characteristic of COVID patient? What could be the characteristic of Takayasu patient, or let's say some new disease? So we will be talking about epidemiological characteristic of such disease where epidemiology is not that known. Okay, let me show you some example and write some of the examples so um, you will have idea. Okay, so here I'm taking epidemiological studies. Probably I'll cover. So epidemiology studies are usually done. Yes. So let's say this is epidemiological studies. Usually epidemiological studies, it's very difficult to publish. It's very difficult to publish. But when we are talking about epidemiological study of rare disease, then many journals would like to accept it because many disease epidemiology we don't know. So this is one of the such epidemiological studies that when they have seen the COVID-19 characteristics for long-term care facility. So probably now by 3 months past, we all know how COVID-19 symptom present, how what are the concurrent comorbidity, what are the complication, what are the people, different people are using different treatment, but still in long-term care facilities, people don't know probably what type of patients are involved, right? So in such case, whatever epidemiological characteristics are, they will produce in this table. Let me show you. This is important thing. When we talk about epidemiological characteristic, it's a simple study, one table. It says that demographic feature and clinical characteristics of the person who is in the facility. I mean, this is long-term facility. So those people are very old, then 83-year-old patient, if they are the patient, then how it look like, whether they are having hypertension, what will be the prevalence of diabetes, etc., etc. So this is like a epic stories, like they have mentioned everything, descriptive studies, but still it is original article. and if your hospital, if let's say for example your place where you do not have sophisticated technology to do analyze the work, no biostatistician, no one, still you can publish such study which is having epidemiology, it is publishable, right? So here we will discuss in future like what are the different tools you can use it wherever you are practicing to publish your work. It is not necessary that you should be in a biggest hospital of the world in order to be the researcher. No, you can be a researcher by practicing in a small village, still you can publish your work very efficiently. Okay, let's get back to our types. We'll cover today all the types. So that is epidemiological studies. Now, second type of research, interventional studies. This is little tricky. Interventional studies always require IRB permission. Always. Those are called intervention. The name suggests you are doing something, you are interventing something, you are giving something to the patient. That is why it's called intervention study. The name suggests suggests it very clearly, right? So now what different type of interventions available? Can't access hospital EHR data unless active employee. Yes, you cannot access the EHR data, right? So that is why some of the study you can't do that, but many of the study you can do it without requiring, we will cover that thing, that you do not require EHR. You can create the database by yourself, create the COVID database, create the other database, and so many databases for your own self. It will be little hectic, but you can do it. And there are many healthcare databases available for research purposes. Yes, they are there, so you can have those databases for your research. Intervention studies. So first, intervention studies having many different type, and those are divided in from phase 1 to phase 4 type of intervention studies. So that we will cover it later on, but the whole our course will be structured on observational studies, because most of the audience here, they are either students or residents or fellow or practicing physicians having less resources, right? So observational studies are the studies which they can focus wherever they are, depend on their resources. But let me cover briefly the detail of intervention study as well. So intervention studies are probably single blind, double blind, or triple blind intervention studies. So single blind intervention studies means patient is not aware about what patient is receiving. I'm sharing my screen so that you will have, I can write there. Okay, so single blind means patient is not aware about. The double blind means the patient is not aware about, as well as the doctor is not aware about what he is giving. Standard computerized system will be there, which will generate the code, which will decide which patient will receive intervention medicine, which patient will receive the placebo. So everything will be decided by the system generated codes. And the triple blind studies, even biostatistician who is doing analyzing the data, he will not aware that what is the intervention and placebo group. So this thing will reduce basically the chances of biases. Okay, it's a whole different thing. Once you will have the idea about how to do research, then you will have you can also learn more about the biases, what type of biases exist, and we will cover a little bit of thing when we will be covering to review studies, which is the second type of study which you can do it by yourself. So those biases are something you need to reduce whenever you are performing any studies. So the single blind, double blind, and triple blinds are the various type of intervention studies are there. Second is the randomization and non-randomization. Now, usually intervention studies are randomized or non-randomized. So when we talk about randomization, so we talk about, let's say, for example, we do not want to be biased about selection of particular, that's a community, or selection of particular disease, or selection of particular group. So in that case, we randomize the population, even though we have to make sure in our study the age group is randomized properly in placebo as well as in a treatment group. The older patient and younger patient must be equally equally distributed, right? So we randomize those people properly. So those are the randomization occur by various way. Randomization occur in various conditions. That is a whole different topic, but randomization is important in order to reduce the biases. And some studies are non-randomized. Let's say if I would like to see the role of IV immunoglobulin reduce the HIV related peripheral neuropathy, then I have no other option than taking HIV patient, and whether they are old or young or severe or non-severe, I have no other option, right? So that will be non-randomized, right? Similarly, some studies are open label, some studies are non-open label. Open label and non-open label means I will not tell patient that which you are getting medicine, it's a placebo without label, or I'm giving you with the label medicine, that XYZ the medicine I'm giving you, right? Let's say the current scenario, COVID, right? I cannot be enrolling the patient in non-open label. I have to keep the label open. I'm giving you remdesivir and I'm giving you remdesivir, right? Similarly, IVIG in HIV, I am giving you IVIG, then I'm giving you. So it is open label trial. So it's up to me, or it's up to basically investigator which type of trial they are designing, but usually some of the important trials are open label as well. Now crossover trials are the trial. Usually what happen, you cannot deprive any patient with the standard medicine. Let's say some new medicine came into the market for HIV, let's say, and you are comparing the let me add here. There is a two group of patient, both group has HIV. You are giving here standard HAART antiretroviral therapy here, and to the another group, you can't say that I'm not going to give you, this is the standard therapy, right? And the new therapy, you don't know efficacy of new therapy. In that case, you will be given them this therapy plus you will be giving them new therapy, right? So this is how usually this is called, here I will call placebo, and here I will call intervention. Here I will call intervention. Why? Because this is the new drug has been given, but sometime this is the new drug and we are checking the action, efficacy, immunogenicity, safety, and so many things. That is why we are using in one group, and one group is the placebo. Some studies are there where we don't give anything, and here we give medicine, but it's not for the emergent condition. This is HIV, you can't deprive patient from basic standard therapy which is already proved. But let's say many studies came out and says that remdesivir is very helpful in COVID, right? Now in that case, people will argue, why not I am getting it? I will enroll if I am in a position of argue. Okay, if I'm getting, if let's say I wish to have chance of getting medicine, and if medicine available in future, why not? Then there is another option to plan the trial like a way called crossover. Crossover means, okay, right now you are getting placebo, you are getting standard medicine, means placebo with new medicine. After 6 weeks, whatever people are in the treatment group, sorry, are in the placebo group, they will get new medicine now, and whatever we are taking new medicine, now they will not receive this medicine, and they will be on placebo now. So what are going to happen? I'm going to first take all the all the outcome measurement here before starting medicine, all outcome measurement. Then before switching them, I'll take all outcome measurement here. Now what is outcome? Basically outcome means the goal of the medicine is to improve their cardiac function, for example. So I will check cardiac function here. followed by I'll check cardiac function here, and then I will switch over. I'll cross over them and I'll check cardiac function here. So this way, this group is happy, this group is happy. Ultimately, everyone is getting medicine if you think it is appropriate. And again, it depend on pharmaceutics, it depend on the investigators, sub investigator, and so many things. But such trial do exist, and we call it crossover studies. We do not have to focus more. This group, this course will not cover intervention studies. If we are having chance in future, we'll see. Otherwise, our major focus will be that, and review studies. Okay, now third type of research is called review article or review studies. Some people think that review studies means non-original article, you are just writing story. No, review article does not mean literature review alone. Review articles are having many type. Many physician who is here, who is actively practicing and maybe actively researchers, they might not even know that this many type of review study exists. So let's cover with the review studies. Number one type is literature review and narrative review. In the next session, I'll cover each and every this subsection, this subsection with example, with each and every. Okay, so we will have a clear idea of differentiation. What is the literature review and systematic review? Systematic review and systematic review with meta-analysis, or with meta-regression, or with survey study. We will try to cover everything one by one. Okay, so literature review or narrative review, that is the storytelling article. Whenever you have 1 weekend left and you have holiday or something, and you think I have this idea, I would like to write something, you can collect selectively 10 article or 15 article, write in a specific order, whatever way, but specific order, whatever you wish to write, in a favor, in oppose, write, prepare a report and submit. Now, problem with these articles are they are having a huge bias. There is no method, there is no methodology. This review article, literature review, literature review has no method. If no method means no result, no result. Now, if your article has no methods, no results, why someone should accept? Why someone should accept your findings? So your bias, you find out whatever 10-15 article or from PubMed or from wherever you wish to write, and you wrote it on in your favor. Tomorrow I wish to write the role of HCQ in COVID, I will write it. Whatever article good in favoring, I'll collect them and I write and submit. So you do not require, the way, if you follow the protocol, you do not require IRB or ethical committee permission to write such article. So now what will you do to make your literature review strong? I tell all my students and all my colleagues, it's kind of when you are reading the research on in the journal, reading the research is completely like a dating a person, like a man or woman. What are you going to do? You are going to see the picture and a small 3-4 line of 1 or 2 line of introduction on any dating website or matrimony website, that okay, picture is good, 2 lines are good, that is your abstract. Okay, so you have to be very careful. The abstract of your literature review or original review will be very strong. Otherwise, I have like 15 journal in my rack, I never read those things if it's not interesting any article, right? That is the first step. If you would like to attract someone, you need a good picture, a good brief 2 line of introduction. Similarly, you want to attract more researcher, more physician, your research should have a good abstract, condensed abstract, that is the picture, the face of your research. Similarly, let's say now you went to the date and then you meet 5 minutes or 10 minutes. What you gonna judge? You will be judging the brain whether it's intellectual, person is intellectual and keep continue to talk for probably another half an hour or not. That is the second thing, the compatibility you're gonna check. And third, the heart is good or not, so that you can spend the rest of the life with them, right? The three things you want to check. The similarly, the method and research is the brain of your manuscript, is the idea, is the brain of your project, right? Which is deciding sustainability. And the discussion, the way you argue your finding, it's the heart of your study. So if the discussion is weak, if the method and results are weak, or the abstract is weak, in that three cases, introduction, probably, yes, I'm not telling no one read, people are reading, but I'm just telling you that a result is the thing people will see. Table, see, we didn't focus much about other part, we just read result, discussion, abstract, boom, finish. So it's exactly same. I always compare that three thing. You want to see the picture, you want to see the brain, you want to see the heart, all three things. The similarly, you want to see the abstract, you want to see the result, and you want to see the discussion. Now in review article, method and results are missing. So here, what is the important point you focus? That is the tables. How strong your table work. My screens are, 1 second. I'm just sharing again. Okay, so important part is the table, and I always recommend people to make in literature review strongest table that you can see, and you can show it to the reviewer. Okay, we will see all the example, but I'm just telling you that such thing can be publishable if you are having a proper tricks. We will pass one by one to everything. Okay, now second, systematic review. Now, what is systematic review? So systematic review, the name suggests it is a systematic. It follow a standard protocol. Either you follow Prisma protocol or Moose protocol or any protocol. Because it's a systematic, it will reduce the bias. It is following the method. It follows the method, then you will produce the result too. And if you produce the result, you can present in a form of table very easily, right? But this result will be different than the result of the third category here, that we will talk in detail afterward. But I'm just telling you the brief information. The systematic review is the review some journal consider in original article, because it is not having analysis, but it will still have method, it will still have method, it will still have result. So what you are going to do is, you will decide your aim of your study, you will decide your aim of your study, you will go on PubMed, you will go on Scopus, you will go on Google Scholar, Web of Science, on different search engine. You will use the particular keyword on particular date on human or particular age group. The criteria will be decided. We will cover each and individual thing later on. So you will be covering everything, and you find out the article. So you will not be biased. This is not like whatever article you wish to choose. You will be following the thing. You will be getting those articles, whether it's in favor or not in favor, you need to cover them. That is your systematic review. So method will be there, result will be there, right? But result will not be in a form of analysis, right? So some journal says yes, it is original article, some says no. We will come to the complete new category. We will discuss the type of original research, type of non-original research, and there we will discuss all this. There's independently all these examples. Okay, the third part of systematic review and meta-analysis or meta-regression. That is a definitive original article, do not require IRB. Okay, meta-analysis and meta-regression, those are the term. When we are using those terms, where similarly you are following all those protocol, first you are following protocol, we'll come to that protocol. the protocol. Either you have Prisma, you have Moose. If you are doing case study, then another one, you are collecting data. Someone was telling me, if you are not having data, so you collect the data using all this protocol. They are all those protocols exist. You collect the data. um, we will cover those all protocols. Okay, so you follow the protocol. Basically, after you follow the protocol, you use the search engine. You collect the data, you collect the article, collect the data, in Excel sheet. Once you collect the data in your Excel sheet, we will try to, I'll show you the all different type of data we have collected throughout the years. We'll show you the quick glance of those data. So you collect it, you use either comprehensive meta-analysis software, review manager software. There are many software online. You SAS software. SAS is probably barely doing it, but there are analysis, meta-analysis. You can Google meta-analysis software, so you'll get a list of software. You upload your data there, and that data will give you odds ratio, hazard ratio, or relative risk from those things. So let me give you a quick example of COVID only. So COVID-19, China says that the people in our ex hospital, the pooled prevalence of smoker, the people who were smoker, those patients are having 3% only prevalence of getting COVID. Okay, 3% prevalence. So COVID-19 who had positive, out of that 3% were only smoker. Okay, that is one hospital says. Another hospital says, no, 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 in our hospital it was 15%. Now US, one study published, and they says like 35%. Now ultimately, whom to trust, whom to believe? Everyone is right. So 19 studies published. Let's say we collect data from all 19, and we submit those data to this software and tell them to find out a pooled prevalence, a pooled prevalence. So that software will tell you that, okay, the pooled prevalence is, let's say, 9%, with confidence interval is, let's say, something between 4 to 20. So what does it mean? That means is from the publication published in all those 17, 18 country, 19 studies published, the total pooled prevalence is 9. So now you tell me whether this data has a good value, which is internal data, or let's say this data is having a good value, or let's say this data is having good value. So this data is giving you internal validity of that hospital or that country. This will give you a good internal validity. This is also internal validity, but this will give you external validity, because you are representing so many different countries or so many different studies together. Now after 1 year, someone wishes to continue the same study, but now he or she will be adding 10 more study, and this pool prevalence will change. So now you are going towards more and more accuracy. Am I using the same data and adding new data? Answer is yes. Is this study is called again original study? Answer is yes. Is it still publishable? Answer is very yes. And is it more accurate than previously published all study? Answer is yes. So research is continuously, it's a dynamic, and it's continuously changing the finding. So today whatever is present may not be the finding tomorrow, right? And this type of study requires a basic information of research, is not requiring your IRBs, because these data are present already on PubMed. You just have to use the system, and you just have to make sure the data you download, you review those data, and you can find out that. I will try to cover, Urja, your question again. Can you please repeat the tool? I will put the link there down once we finish that. Oh, someone is putting there. Atal is putting that. Okay, thank you, Atal. Yes, so this will give you the pooled prevalence, one thing. So this is just the pool prevalence. This is very basic thing. But if one clinical trial is telling that X device is having a hazard ratio of 3, right? This is device is in favor, device is in favor and device is in not favor. So this one study is telling that this device is not in favor. Another study is saying device is in very very bad, right? 4. Some study says no, it is probably not in favor, probably 1. Some study says here is the finding, some says here, some says here, some says here, or let's say if everyone is saying even these are the finding, then it's very difficult to get the common answer. Then this software will tell you if it is in favor, how much favor, whether it is favor or not, and if it is in favor, how much favor. So even though, let's remove this 3 study, and if we want to know if this is in favor, then it will tell you that though these people are telling it is not in favor, these people are telling it is very much in favor, but middle answer is somewhere here, it is probably this much in favor. So this clinical trial, one is good, probably 30 patient, 20 patient, 50 patient, 100 patient. But now my study, without IRB, without ethics committee, without spending any money, my study will have 100 plus 50 plus 30, 20 plus 30, 200 patient. And this is called meta-analysis of clinical trial. And this is going to be the good article because now I'm merging the result of all of them, right? So that is called another, this is meta-analysis only, all different type, with whether I'm getting, so basically I'm getting pooled prevalence or I'm getting hazard ratio, but it's called also pooled hazard ratio, right? Because every study has their own independent result. So that is called meta-analysis. Meta-regression, when we talk about meta-regression, then meta-regression is the similarly is just going to tell you, let's say, very interesting thing. One study says that this is the number of cerebrovascular disease, let's say stroke patient, the patient who is having um, let's remove this part here and write it here, stroke. Okay, COVID patient and arrhythmia, probably more people are interested in that probably. So probably in my hospital, let's say these are the 10, 20, 30, 40, 50, these are the percentage, okay, and these are also percentage of arrhythmia. So one study said that in my hospital, one study says that 10% COVID hospitalization occur in my hospital, and 5% were having arrhythmia. So this dot is presenting value of 10 x-axis and 5 y-axis. Another study came out. This is study number 1. Another study came out. This is of 10 patient probably. Okay, 10 patient. Study 2 came out, says we are having 30 COVID patient or whatever, let's say 30 COVID patients. I'm not taking percentage yet, let's take patient number only, 30 COVID patients, and we are having 25% of arrhythmia. 25 follow somewhere here, let's say. I'm making the big round. The size big means more number of patient, right? The computer will do it, nothing you are doing it by yourself. Computer will produce such result for you. The third study came out, I'm having 5,000 patients of COVID, let's say somewhere here, and I'm having more number of arrhythmia. So study size, so they will produce a dots. Every dot has, these all are study 1, study 1, study 2, study 3, study 4, study 5, study 6, study 7, and computer will uh, by itself pass a line from it, and that line will have correlation coefficient, Pearson correlation, right? Or maybe odds ratio. You can convert those finding into odds ratios. So it will tell you the small finding is there, but very effective finding. The number of COVID patient increase, whether the prevalence of arrhythmia in your institute increase or not. Number of COVID patient increase, the needs of mechanical ventilation increase or not. Number of COVID patient increase, mortality increase or not. So that will help you to identify at a bigger level the resources utilization. This is a very huge concept, but I'm telling you very small thing you can perform which will change drastically to the healthcare system. That does not require your affiliation. Someone asked me about affiliations, that do I have to have it affiliation or not? Okay, so those things you can do it without having any affiliation. Okay, survey studies. I'll cover this survey studies and we will end today's session here. Survey studies are also very effective way to do. It's also called original study. It's very effective way to analyze the people's mind. Survey studies are the studies. Let's say you are following again the protocol, sending surveys using standard survey softwares, contacting patients, contacting doctors, resident. Different type of survey exists. Harvard and Johns Hopkins and many big hospitals right now doing surveys. Even in fact, we did a survey, and then on that surveys, your people are responding or doctors are responding, and you are getting the response back. You are analyzing that response, and you are publishing that response, that this is the problem, right? And those surveys are varies between the whether telemedicine is helpful or not, you are satisfied or not, whether you believe in face mask or not, whether COVID condition will finish, you will go out without mask or with mask or not, whether your hospital is providing proper care or not. The survey can be very basic, survey can be very complicated. So depend on how much complexity you would like to create, you can create in that survey. And those are, so basically we are having, one is this group, one is this group, and one is this group. Three different type of research majority are there. Yeah, three different type of research majority are there: observational study, interventional studies, and review studies. Other than that, I do not consider case report or letter to editor or perspectives or viewpoint as research, but people still write it. It is everyone's personal point, personal view, but I definitely will show you, if you are having a case report, how you can collect other case report, publish online and submit here, either in systematic study or literature review, or even you analyze and put it in meta-analysis. Okay, that is a different thing, but one case report will not change anything in research field. One case report. But there are, I have never seen any disease where only one case exists, except very rare, and I was not that lucky, now ever that lucky, that getting that rare case. Okay, but still, if you are having time and you don't have anything, then you can write definitely case report. But for writing case report, for sure you need permission from institute, patient permission to participate, and patient permission to publish that case. Three things you require it. So that is the case report. And other than that, you have letter to editor, viewpoint, perspectives, and so little small categories of the thing. Those are not research, but those are still your viewpoint. But it's very difficult to say whether anyone will accept it or not, except you are invited to do so. Once some people reach to the very good position, people invite them to write something, and then they can do that. So this is the type of research. Yes. Now we can, here we can end our session, and next time we will continue with, one second. Yes, we'll continue with the introduction to the manuscript writing with original and non-original, and we'll try to cover everything in detail one by one. How you can write original article into full length, brief, research letter, depend on your time and everything. That will be the next time's topic. Now, two way we are going to answer quickly, 10-15 minutes, the question, one in the chat box and one by raising the hand. You can raise the hand if you're having it, and I'm reading the chat box question very quickly. Dr. Khan asked that if I have planned to do meta-analysis but I find only 2 to 3 articles, will it be less chance to publishing? No, you need minimum 3 articles for meta-analysis. Once you have 3, it is still worth to publish, or you can wait for one more to add. Okay, but minimum 3 you require. I have already published the case report, and in in concrete Canada syndrome, still can I use it for meta-analysis? Yes, you can use it, and you can cite that report in meta-analysis when you are having 15 more similar syndrome report, and you can cite. So it will make your previous report strong, as well as it will give you citation. More citation you are having, it will increase the value of your work. Anyone else is having question before we end this session? And I'm thankful for like such a big group, and I really appreciate. I was not expecting similar session will have this big response. Thank you so much. Can I have okay. Mm, I have a case on BRIC, benign recurrent cholestasis. Can I make a case report? Yes, you can make it, but try to publish case report and literature review, where in the beginning you will have a case report, and on the bottom you will make a table for your case, and so many same case publish online, and you can write case report and literature review rather than just case report. As I mentioned, only one case report will not make any sense to it. Your treatment, what you gave it to patient, might be very drastically from other people. So try to collect more cases, put it in a literature review form, so it will increase the chance of acceptance. Are we going to discuss literature review? Yes, we will be discussing. Nikhil, I'm a student myself writing a research article. Let's say review article. How can I approach that? Review article, I will show you the approach how to do that. You can this course you can join this current course, you will know how to do that, and we are also having a exclusive course for the fast track for the people who wish to have it like 4 day 3-4 month to publish. That is another thing which we will also talk about later on my Facebook page. You can see all the different discussion on that course as well as this course. We will try to cover everything here, but we will try to see that how quickly we can cover that here. And your approach should be read those article, put it in one folder, and then start writing introduction first, and then create a table. I tell my people, never ever write discussion without creating a table. First write the table and then start the discussion. So compile your article, make a table, and then next step will be the discussion. How good is it to do a meta-analysis on previously done topic? Definitely it is good. Previously published topic means what, I don't know, but if you are having 3-4 observational studies or 10 observational studies or clinical trial, meta-analysis, you can do it. Definitely do it. If 10 meta-analysis are there, you can do umbrella meta-analysis. That is another way to do a meta-analysis of meta-analysis. How does it takes to get published? Between 5 to 11 months. It varies the publication time, but depend on your senior author, depend on your team. It varies the time. Because the literature that you can use it in writing the scientific, how should I because the literature that you use in writing an article is scientific, how should I improvise on that? Nikhil, I could not understand your question properly. Because the literature that you use in writing an article is scientific. You can inbox me your detailed question. I'll try to, if I miss any of the question here, because having many question here, so you can definitely write, you can inbox me the question, as well as you can put it on feedback and the question on our course link on the bottom. So I will answer all these questions there as well. Okay, so do not forget to put all this question writing there, so I will write it in detail, or I have my assistant or my colleague or anyone, whomever will be having time, they all will write these answers in detail there. Okay, how easy the Revman and CMA? Revman is free and it's very easy. The YouTube is having a series of 5 to 10 session on Revman. They can teach you that. CMA is extremely easier than Revman, but it is paid, so you have to pay $200 around charge for per year to use that one. can case report are identical for unique case presentation? It is the same. Case reports are ideally for you. Yes, it is unique. So we check, as a reviewer, I always check that if it is the case report comes to me, first of all, it follow the protocol of care or not, it follow the paperwork or not, whether it is legitimate or not, and what is the prevalence of the disease. If that disease is very prevalent, I don't bother to read and waste my time, right? So it must be very, very, very unique. I read some of the name there, and you can also read, if I'm not wrong, those cases are rare. Okay, those cases are rare. So something Canada, Cronkite Canada syndrome, and something they wrote it there. So you can write on that, but still I encourage you, even though whatever the rarest rare, I published one called smart syndrome. Even though it is a rarest rare, still we able to find out 40 cases in the world. So jot down all 40 cases and write it. Okay. Will you teach Rahman as a part of the course? That course probably then it's going to be 1 year course. But first of all, we'll try to cover basic slides, which are like almost more than, it will take more than 6 months to my expedient course, which is a paid course, which is educational course plus skilled and hands-on training. That is 4 month course and 2 months of additional advanced course. So if Ravman and everything will be teaching here, it will be like more than a year. So, but I will try to share videos and think with you, and that is easy to comprehend, definitely. And if you have question, you can ask me for sure. um is it good to do, will it get published if I'm trying to do a meta-analysis on uncontrolled and single arm studies? Yes, it is. Look, there are probably in market 200 plus journals. Make sure there are ghost journals. Ghost journals means they will take your publication and they will run away kinda means they will take the money and everything. Your article must have DOI number, must come to Google Scholar minimum, right? And then ideally it should be on Scopus and PubMed. If it is PubMed index, Scopus index, then it's good. Google Scholar index, it's good. But yeah, it's having a good chance of getting published. There will not be the problem if you follow the standard protocol. Mm, can I get published if the data I have it from 2016? Yes. There is no problem if the data year matters. But let's say the prevalence of let's say you are looking for the prevalence of some disease. Now the prevalence is something will little bit change year to year, but will not drastically change, right? So for such study, yeah, definitely you can use 2016 data, and I still am using 2016 data. In fact, when we are using nationwide data, in USA, the latest data we are having is 2017, and in CDC latest data we are having Center for Disease and those things 2018 probably. So you can use it 2016. That's still very new data, 2016. Also, I joined a little bit late. Yeah, my name is Urvish Patel, and I run this Research Update Incorporation. That's non-profit company registered here in New Jersey. And also, I run Clinical Research 360 course. That's completely different from this one. It's a hands-on training, and this is educational course. Can you share guidance recording how to publish the study? Yes, we will cover that thing too, Srushti. Can I discuss the data I have with? Can I discuss the data I have with you after the class? You can, but usually if it is a data affiliated with some hospital, ideally you should not, because that is something will create the conflict of interest. But still, you can write me in inbox and we'll see what we can do. Okay. So today we can end up our session here, and thank you so much to everyone. We will upload this video on YouTube as well as Facebook, and whatever question you're having it, you can put it on our group page. There people can have discussion. My assistant and my colleagues and other instructor can try to answer as well. And also you can watch the video. The people who miss the thing, they can they can watch this video from there. Okay, and tell your friends and other colleagues to join next time. So we still have like 20 spots available for today's session, so probably we'll have, I'm expecting 80 participants, so you can still invite more people if you wish. Okay, thank you so much. We'll see you. Enjoy your weekend and rest of the week. Bye bye. Bye. Thank you. Thanks everyone.